Hello and welcome. Thank you so much for joining me today. My name is Brianna Birkin, pharmacist and physician liaison with Physicians Preference Pharmacy. During today's webinar, we are going to discuss Amlexanox, of course. And so this is something that I have discussed before, but we are going to be revisiting it because it is a product that has went on back order as of last October. That was October 2025. And we did not have the opportunity to have it in stock for several months, unfortunately. So I'm so excited to come back to you today and to discuss it, to unpack what Amlexanox is, so that we can better serve you, better serve your patients, and we can come together and kind of brainstorm for some of the patients that really actually need this product. So here I am showing my screen. I'm going to go ahead and start showing my slides as I always do. I have a presentation prepared for us today, and we're going to do things a little bit differently in that I'm going to unpack the pharmacology of this drug, of course, and we're going to talk about the applications, but I'm going to round this out with a couple of case studies, which I don't always have the opportunity to do, but this is extremely important because this is what allows you as the prescriber to gain confidence before you start implementing it into your practice of what we're already seeing. So I'm very excited to wrap up with those. So let's go ahead and dive right in. So we're going to talk about compounded Amlexanox, and this is a product that is not commercially available anymore. So it is only available as a compounded product. So my intention today is to help you understand what it is. If you've already heard me talk about it, we're going to talk about the broader relevance of application within inside your practice. So as always, I like to start out with who we are and what we believe. We know that we do things a little bit differently at Physicians Preference, and we're very proud of that. So we are a compounding only facility. We're 503A, and we're non-sterile. So we don't do any injectables, anything for the eyes, any IV preparations. We do not compound for office use. We're focused on the individual structure of providing the best and personalized experience for the patient. We believe, of course, as pharmacists, that we are crucial in the whole patient prescriber and pharmacist relationship triad. And so we want to help maintain that. And really, we serve as the support for your practice and echoing what you're telling your patients. Within that, we know that our scope and our due diligence is to provide the most consistent and pure products for your patient. So as a compounding pharmacy, we do focus on personalized preparations, and at the same time, we see trends and we see the opportunities to be able to serve your patients in a way that helps them understand what their prescriptions are for, how they take them so that they get the most out of them. And part of that responsibility is actually us doing additional testing. And so a lot of pharmacies either cannot implement this into their practice because it's too expensive, it's too costly to get started, or they do not really understand actually the purpose of on-site or third-party testing. That's something we've been doing for a long time. And again, we're very proud of that. We're grateful for the opportunity to be able to do that. So we are set up on site to weight test everything that is compounded within our pharmacy. And weight testing is something that compounding pharmacies utilize to be sure that the right amount of active and the appropriate inactive ingredient is present in the preparation. So it's more than just putting it on a scale. We use sorters to weigh out and to sort the products that we should keep because they pass spec and those that we should not because they don't pass spec. And then we have several technicians that work in our compounding labs, and we send out samples from each of those compounding technicians each week to third-party labs for third-party verification. Additionally, we do batch tests as well. So we be sure that we quarantine those products until we do receive the third-party testing back to ensure essentially that what you're prescribing is actually what we're making and actually what the patient is taking at the end of the day. Unfortunately, we hear about a lot of variation between what compounding pharmacies dispense. And of course, we don't want anyone to get a bad name, and we want our profession to be protected. So that's very important to us. What we're going to be talking about today is an oral capsule formulation, but I just do want to let you know that we make all kinds of non-sterile dosage forms to also include sublingual tablets, which are really important in our hormone preparations, particularly. Oral suspensions, topical and vaginal creams, and then nasal sprays are also a favorite. We do ship to 49 states, and so we actually work with prescribers in 50 states. The licensure in the 49 states just means that we can only ship directly into those 49 states. So it excludes Alabama, but we do have patients that are in Alabama. We just have to get their prescriptions to them a different way, sometimes with the help of a designated agent or family member. Now, all prescriptions must be patient specific, as I mentioned. I get a lot of questions about, can I pay for my patient's prescriptions? We do not allow that because actually it's multifaceted and there's multiple layers to this. I have seen prescribers get in a lot of trouble for this, either because they shouldn't be doing it or it's not done correctly. Ultimately, what you need to be looking out for is, why are the costs of prescriptions being marked up if you're selling directly to your patients or getting those from the pharmacy and reselling or bundling it into the whole entire cost of a service or a membership. So just please be careful with that. That is the anti-kickback statute, which is a federal statute that you do need to be aware of. And we don't want that to be misconstrued with fraud either. Now, we do also hold PCAB accreditation. So that's kind of what I touched on with the on-site and third-party testing. And so that is a voluntary accreditation that we do seek out to be sure that we have stricter standards than just what the state boards tell us we have to abide by. All right, so Amlexanox, this is why we're here. Who is this for? How can I help you better identify these patients in your practice? So my question for you is, do you have patients with chronic inflammatory conditions, autoimmunity, metabolic dysregulation? That's kind of a joke. We're seeing that all the time now, right? And other chronic conditions who are treatment refractory. That's always a challenge, especially for chronic conditions, especially for chronic gut conditions, chronic skin conditions. We hear a lot about treatment refractory issues in our patients. All right, so let's go ahead and gain an understanding here, a baseline understanding of what Amlexanox is. Chances are, unless you've heard me talk about it before, that you've never heard about it before because it was commercially available at one point, but it's not anymore. So you're not seeing or hearing the drug ads for it. It's not available at your retail pharmacy. So it is more of a specialized product, but we've really began to understand over the past several years of compounding this just how special this prescription is for a lot of folks. So it previously was branded as a product called Apthosol. That was an oral paste, and Apthosol was originally used topically inside of the mouth for recurrent aphthous ulcers that either came up because of immunosuppression or even perhaps from treatment for cancer. And that is an indication of immunosuppression, are those aphthous ulcers. And that's what Amlexanox was originally approved for. Now, I'm talking about the United States, and it's no longer made to be sold as an FDA product in the United States, but it's still being used successfully and widely in other countries and other places like Japan. And primarily, they're using this to treat issues like asthma, allergic rhinitis, and conjunctivitis. Now, it shares structural similarity to products that I'm sure you are familiar with: cromolyn, nasal crom, gastrocrom. And this is because it functions as an antihistaminic mast cell stabilizer. I talk a lot about mast cells, mast cell overactivity, mast cell activation syndrome, which is MCAS. We are going to talk about that today because that's super relevant for this population. Now, Amlexanox is considered to be a novel anti-allergic because it does share some structural similarity with some super common drugs, but the way that patients react to it is very much different. And so it does function as an anti-allergic, but also an anti-inflammatory. And Amlexanox has recently been found over the past several years to have a much broader range of applications. So we're going to be talking about those. I have a table and a list for you so you can identify what types of patients in your practice can be good candidates for Amlexanox and why they can each individually benefit from it. Now, this does range from metabolic disease to mast cell stabilization to immunomodulation, and also for the correction of gene expression. So there's a lot of areas that it's covering. So again, who's a good candidate? Back to one of those first slides, those with chronic issues like chronic inflammatory conditions, autoimmunity, mast cell activation, which is MCAS, and metabolic dysregulation. Chronic and treatment refractory skin conditions, We see a lot of benefit with Amlexanox for eczema and psoriasis, and also those who desire weight loss support. Notice I didn't put that this is a weight loss drug here because it certainly is not. That would not be setting a realistic expectation at all. However, because it is anti-inflammatory and because it can help to mobilize and kick into action some of the lipolysis that happens specifically around visceral fat, and Lexanox can have a place in therapy for those that are desiring weight loss support. Additionally, for a few other reasons, it's an anti-inflammatory. And so for some folks who are very overweight, and their mobility might also be limited. Therefore, it's hard for them to be active and to utilize the activity part of nutrition and activity to help them achieve their ideal body weight and maintain it. This can help take the load off initially for people to help them kickstart their weight loss journey. And we'll see an example of that here towards the end of these slides. So think about conditions related to T helper cell dysfunction as well, because that's a really big deal here. So Amlexanox and immune balance. When we think about people that are good candidates for Amlexanox, we think about people who have some sort of immune dysregulation or some sort of inflammatory dysregulation. Just like I said about T cells, Amlexanox actually acts on T helper cells, balancing Th1 and Th2 and reducing Th17 overactivity. When I think about that, I oftentimes think about patients that would be a good candidate for LDN, especially when we're talking about Th1 and Th2 dysregulation. And that's true. So if you're already using low dose naltrexone in your practice, those are kind of along the same lines of folks that we would use Amlexanox in. But in my years of experience seeing patients that are taking LDN and then taking Amlexanox later because they knew about LDN first before the Amlexanox, we have a pretty good group of individuals that have given us the information and the feedback about what is the difference from being on Amlexanox, what is the difference for being on LDN for months or years, and then coming in and adding Amlexanox, and what is that change? Amlexanox oftentimes will sweep up, as I like to say, or kind of clean up the mess that LDN is left behind. LDN is a phenomenal drug and it has a wide range of applications. So if you're already using that in your practice, this should speak even more volumes to you that Amlexanox can kind of clean up the mess that LDN has left behind. Additionally, when we think about Th17 overactivity, we're always thinking about autoimmunity, inflammation. We're also thinking about cancer in this space as well. So when we think of symptoms of Th1 and Th2 dominance, what does that look like? Someone who has Th1 dominance, that can look like delayed food sensitivity, fatigue after meals, low T3 syndrome, thinness, so some dysregulation of the appetite as well. And then Th2 dominance would be more so like the skin allergies, the mucosal or the nasal drip, also eczema, so some of those skin issues that we might see, especially that are treatment refractory, GERD, histamine intolerance. A lot of this, of course, overlaps with your mast cell patients too. All right, so let's talk about metabolic dysfunction. This, of course, is a huge topic of conversation, more than it has been before, because we have many toxins and exposures within our environment, but also there's the whole GLP-1 conversation. And so people have this on their radar maybe when they didn't before, and perhaps having a better understanding of what metabolic dysfunction is, about the parameters that qualify for metabolic dysfunction, and perhaps what can qualify someone for a diagnosis of metabolic dysfunction and therefore a prescription for something like a GLP-1. Again, Amlexanox is not a weight loss drug, but interestingly, it does inhibit some characteristics in the body that support glucose control. And so what we have seen on labs for folks is that amongst that glucose panel or glucose control panel or type 2 diabetes panel or pre-screening for something like that, we've seen much improvement in insulin resistance. And hemoglobin A1C is something that is wildly improved for patients as well. So for this particular study, this was actually an open label study, and the dosing of this study used Amlexanox to ensure the safety. The dosing was to ensure the safety. So this is 25 milligrams of Amlexanox taken 3 times a day. And there was a measurable reduction in fasting glucose, fasting insulin. Insulin resistance was improved, decreased hepatic glucose production as well. And then on the back end of this, there was a proof of concept study following that open label trial, and the dosing is a little bit different. So it's actually twice of what it was before in the safety study. So rather than 25 milligrams TID, it jumps to 50 milligrams TID. So we're going to talk about dosing here in a moment, but just to give you a ballpark, most patients, I'm going to say 90% plus patients that use Amlexanox use a 40 milligram capsule once per day, and that gets them significant improvement in symptoms. There are other reasons why we use more than that. There are other reasons why we use less than that. So 50 milligrams 3 times a day is quite a bit, but if we're talking about metabolic dysfunction, we generally dose these types of drugs that assist with glucose or assist with some of the parameters around appetite 3 times a day with meals, so that makes sense. We know that there's an inflammatory link between obesity and type 2 diabetes, of course. So for the parameters that we mentioned that Amlexanox has an effect on, we can see an improvement in weight, insulin resistance, fatty liver, and inflammation. Fatty liver is also really important. I don't really think that gets acknowledged enough, and I also don't think a lot of folks have something in place to help with fatty liver, but we see that a lot. And so for this double-blind, placebo-controlled study of 42 obese patients with type 2 diabetes and non-alcoholic fatty liver, there was a significant reduction in that hemoglobin A1C that I was referring to, and that's with that 50 milligrams TID. Okay, for my table people, I have a few slides here of Amlexanox benefits and uses. This is something that I pulled together just based on either the diagnosis someone comes to you with, or perhaps you've diagnosed folks with it, and then what's the mechanism of action that Amlexanox comes in to provide to assist with the symptoms associated with that condition. Mast cell stabilization, mast cells, MCAS, it's kind of one of my babies. That's one I focus a lot on because we see it all the time. And I'm so glad that more people are noticing it, more people are diagnosing it. Hopefully, that's partially as a result of our conversations and our talks around these webinars and case studies and things like this. But you can't get around it post-COVID either. Things that perhaps were lying dormant in the patient's body have really reared their ugly heads as mast cells go on fire. So mast cells are a type of white blood cell, which is a type of immune cell. And they really are responsible for full-time 24/7 around the clock surveillance. So they are circulating the body and they're asking one question. It is, am I safe? And if the answer to that question is perceived as no, then the mast cells go into overdrive. And so there's an issue with overproduction of mast cells, which is not the most common issue. There's an issue with overactivity of the mast cells that we have. One of the tricky things about nailing down how to treat someone that has symptoms congruent with mast cell overactivity or mast cell activation syndrome, MCAS, is that these cells, the mast cells, they live in virtually every system of the body. So if you are a hepatic specialist and you are dealing with things just in the liver, it keeps it much more confined. If you're a gut specialist, it keeps it much more confined. Of course, everything is connected. But my point here is that mast cells love the central nervous system. They love all types of tissues. They love the skin, they love the eyes, they love the ears, they love the gut. They're everywhere. So these are the people that show up and they're like, oh, my labs look perfect, but I feel absolutely atrocious. I can't get out of bed. They are the ones that explain all the weird symptoms, if you will, because nobody believes them, and because they might look fine from the outside, but they feel like absolute trash. And this is a sad deal. So we need to give these people empathy and understanding and listen to what they're explaining to us because they really are triggered more than any subset of patients I've ever met. So how Amlexanox is helpful for these folks is that it helps to reduce the release of histamine and leukotriene mediators in the mast cells. So mast cells, again, are those white blood cells or immune cells, but something that makes them unique is that they're highly interactive with their environment. They're like the social butterfly of cells. They like to interact with everything. One of those being a really big issue is hormones. So you have your female who has fluctuating hormones, is still cycling, and she always feels really bad and has flares prior to her cycle or around times when estrogen is higher. Estrogen is highly interactive with the mast cell, and so when it binds there, they start having this interaction making people feel bad. So when the mast cell binds up to something, or if it perceives some sort of an issue or a threat within the body, it will start spewing its contents like a skunk, the histamine, the leukotrienes, all this stuff that makes you feel worse. It's like a dump from inside of that mast cell. And so people feel real bad. Amlexanox can help to stabilize that function. So it is a mast cell stabilizer. Again, remember, so is low-dose naltrexone. So if we are getting such leaps and bounds more progress with Amlexanox than LDN alone, again, think about how significant that is and can be for patients, either as an add-on to LDN, because we have a lot of patients on both, or perhaps if LDN isn't getting your patient to where they need to go, then we can use Amlexanox instead. I had mentioned cancer. I'm spending more and more of my days focusing on cancer. We're seeing more and more people that come to us because they need repurposed drugs peppered into their cancer regimen or to come alongside. And Amlexanox would be one of these repurposed drugs. It does inhibit Th17, but not Th1. And it also has a place in longevity and inflammation because it promotes cellular autophagy. So that's a cellular housekeeping, cellular cleanup that's going on all the time. And that happens via mTOR pathway inhibition, and it induces apoptosis. So it's really helping to kickstart cellular cleanup. Now, I definitely see the connection between poor autophagy, poor genetic structure to help patients achieve cellular autophagy and cleanup, especially when they're not set up genetically to clean up their own cells well. So these are the people that are usually your long haulers, usually your vax injured, and usually have mast cell overactivity too, and also metabolic dysregulation, because one of the body's first reactions to help to keep it alive if it perceives a threat or a toxin is to bathe it in water to help keep it from the body. And that's why a lot of times we will lose water weight when we are losing weight first. So question, is there a toxicity issue with weight gain? I think yeah, all the time, maybe not, but frequently, absolutely. It's also an immunomodulator because it modulates macrophages, balances those T helper cells, regulates T function. We talked about that. Neurodegeneration, it actually decreases inflammation and oxidative stress. Mast cells love the central nervous system too. So it works as an anti-inflammatory and a mast cell stabilizer in the neuronal spaces. Erectile dysfunction. So it works here because it promotes maintenance of an erection due to the PDE5 inhibition that we see as that mechanism of action for a lot of commercially available drugs used for ED. It also functions as an antifibrotic. So it does this because it binds to fibroblast growth factor 1 and can be useful in atherosclerosis. This is when we can also use it as part of the non-alcoholic fatty liver disease protocol. So metabolic disease, we talked about this, and I did mention this at the beginning, but I'm actually just going to read this one because I think it's so interesting and it's important to understand the detail behind it. So not a weight loss drug, right? But why does it work? Because it stimulates lipolysis via AMPK. It reduces insulin resistance and stimulates the mitochondria. So it's helping to generate energy, oxygen delivery, and lower cholesterol. So if obesity is caused by Th17 driven inflammation, visceral fat tissue may become resistant to lipolysis, which leads to obesity, insulin resistance, and metabolic syndrome. So Amlexanox helps to lower that Th17 that can be driving that inflammation, sensitizing the fat cells to lipolysis, helping to lead to fatty acid oxidation and reduction in fat volumes. Pretty cool stuff. Also works as a vasodilator, so it can help to regulate blood pressure for some folks. We talked about non-alcoholic fatty liver, and then also psoriasis. So a lot of the skin issues that we see resolved with Amlexanox, it's because it's working on that Th1, Th2 cell balance. Genetics. So there's also some fairly compelling evidence that it may correct gene expression, especially in cystic fibrosis. This isn't something that we see a lot, but it's worth exploring. And then one of the most common uses for Amlexanox in our folks is asthma, allergies, and bronchodilation. So it inhibits phosphodiesterase and CAMP, leading to bronchodilation and reduction of inflammation. It decreases the allergic response by inhibiting histamine release. What about long haul? I mentioned long haul and mast cell overactivity are highly correlated. This is very true. One of the main reasons why we see sustained issues as far as symptomatic issues in patients with long haul is because they have that persistent mast cell overactivity. Now, persistent brain fog that we often see show up in those with long haul is largely driven by that persistent mast cell overactivity. So until we can calm that down in the brain and the central nervous system, we're probably going to have persistent brain fog for those folks. We also get good concentration and delivery to the lungs. It also improves oxygen delivery to the lungs, reduces that histamine release and the associated inflammation, and inhibits the IgE-mediated degranulation of mast cells. That degranulation and what happens and what spills out of the mast cells is extremely, extremely important to control. Usually I would have a dosing slide, but I don't because I think this should be more of an open conversation and telling you what we clinically see. So we make several different doses of Amlexanox. We make mostly immediate release formulations as a 10 milligram, a 20 milligram, a 40 milligram, and then we have a slow release formulation, which is a 60 milligram formulation. That one got added to our formulary per request. I watched some webinars and listened to some things, and early on in pharmacies utilizing Amlexanox, there was a pharmacist that had suggested this, not at our pharmacy, but another pharmacy, has suggested that 60 milligrams slow release might be a better, more gentle dosing strategy for folks. And if they only have the compliance to be able to take it once a day, I can get behind that. It doesn't work any better, in my opinion, than doing the others. People that need Amlexanox are desperate and they're going to take their Amlexanox. So most people take 40 milligrams, meaning they take the 40 milligram capsule just once daily, and they do beautifully. That would be myself included. We also make the 10 and the 20, which are lower doses. And so just to step back for a moment and put this into perspective, most people that take Amlexanox are super sensitive individuals. And then you have your folks that are overall otherwise healthy, but they have some sort of offending agent, something environmentally, allergies, something that triggers them that they need the Amlexanox for. But remember, most people we use Amlexanox in are highly sensitive. Like they are the sensitive of sensitive, okay? So in addition to that, what we use as our filler is sodium bicarb, which is baking soda. And there are a lot of inactive ingredients or fillers that may be present in medications or supplements that are highly bothersome to the mast cells. So we have to be very careful of that. It doesn't mean that they're bad ingredients. It means that they're not compatible or mast cell friendly. So this is super important. So that said, even though 40 milligrams is the mid-range dose that we have, most of the super sensitive individuals do just fine starting at 40 milligrams. If you have someone that is your most sensitive patient ever, feel free to start them at the 10 or the 20. I think the only drawback there is they're going to pay more because they have to purchase potentially more capsules to eventually get to the intended titrated dose, which let's say that that's 40 milligrams a day or maybe a total of 120. So most people, 40 milligrams once a day. Take it any time of day. Take it in the morning if they need benefit throughout the day. Take it at night if they need benefit throughout the night. There's a lot of dosing flexibility here. For your long haulers, they're probably going to need 40 milligrams 3 times a day. The highest dose I've ever seen someone go to is a total of 160 milligrams a day. And that would be split up, of course, throughout several capsules. But most people do great with 40 milligrams once or twice daily. Okay, so a couple case studies I'd like to share with you. The first one here is the issue with having chronic EBV that was not necessarily being addressed in this individual. Also suspected MCAS at this time. So this was obviously a few years ago here. So started in October of 2023. And we really started talking about Amlexanox for her a little over 2 years ago. So I wrote up this case study about a year and a half ago after I did a follow-up interview with her to see how she was improving. But let's take it from the baseline. So she's 37 years old at the time. Clinical history of joint pain, fevers, butterfly rash you can see, recurring Epstein-Barr flares at least twice a year, and LDN was initiated by her prescriber to control those flares. She was doing pretty well on it, but she was still having spontaneous food reactions. She would come and say, and you've heard this, I'm allergic to everything, or I'm allergic to everything that I used to tolerate before. And sometimes that's not limited to food. Sometimes it's also includes sun exposure or certain medications or supplements that they once handled, certain types of activity, now they don't. Those food reactions were occurring weekly to monthly, and she would rely on 50 milligrams of Benadryl each time she experienced a flare. So we initiated Amlexanox 40 daily for uncontrolled food allergy reactions specifically, and she also at that time begins to limit gluten in her diet. I am not undermining that because I myself am gluten free. And, and that was initially a choice. I was pretty much forced into that because of my own GI issues. However, I am extra cognizant of what gluten can do for folks. And I don't think if people, they don't understand really what gluten is and why it's not digestible and how the American diet, our standard diet, really has tainted gluten, they are not going to be that excited to take it out. So it can be difficult to paint that picture for folks. However, this is a really big deal for her. For her to take out a major inflammatory food group or ingredient is obviously going to move the needle. But we're, of course, focusing on anything that happened at that change. So adding Amlexanox, taking away the gluten, she gets resolution of her joint pain, the butterfly rash, the food allergy reactions. And at the time that I interviewed her, which was about it was about 3 months after I initially talked to her. But at this point, since her weight loss journey, she had lost 70 pounds. And I actually know this individual personally. And so I see her routinely in person. And it's incredible how she has held off of her weight years later. But what I point out here is not so much that it's 70 pounds weight loss, because that's a big deal, but at 1 pound a week, that's healthy. It's maybe not as quickly as we would want right off the bat, 2, 3 pounds a week, but 1 pound a week is doable because it will be sustainable going forward. She was making dietary changes to accompany this weight loss and this medication ad. It also had a lowered blood glucose effect for her, CRP, and hemoglobin A1C. What she told me when I interviewed her was that the Amlexanox completely cleared up her skin. And I mean, you can see here, this is the side of her abdomen. It looks very painful. And she was getting these breakouts frequently. She said that it completely cleared up her skin and gave her the confidence to get on a weight loss journey. So that's really, the fire in our belly we want to feel about why do we want to lose weight loss? If we need GLPs, we can add them on, but we don't have to be so reliant on those. There are other options that can help people like her kickstart into a healthy weight loss journey, pattern, and habits. All right, so here's one of my poster children for Amlexanox is the case of asthma and severe MCAS. And so this is actually a publication that I had in, I think, 2024 now. And this was for a 60-year-old female with, gosh, a really bad clinical history. So asthma, food allergies, hypothyroidism, sex hormone dysregulation, edema, candidiasis, Lyme, Bartonella, Babesia, blood biofilms, POTS, and MCAS. And, if that weren't already enough, every time that she would take a medication or supplement and add it in, she would get puffy eyes, swollen hands, intense redness of the ears. It would resemble sunburn, severe itching affected the mouth, face, nose, torso, swollen tongue, darkened lips. The reason I read all this out is because that should not be happening when someone tries a new product. But not only was she having a Herx-like reaction like someone might to an antibiotic, she was having it to everything that she tried. So that's a major indicator that something is affecting or connecting the dots between all the systems, right? Lips, face, nose, mouth, torso, tongue. It's not just an allergic type reaction. There's more going on there. Her mast cells were on fire. This patient described a sensation in her calves as if they were quote unquote about to pop, a quote unquote spongy feeling in her scalp, headache, and dry heaving. A lot of folks that have real bad mast cell overactivity after trying a new product will say that they feel like their brain is too big for their skull because of the neuroinflammation. And so Amlexanox has been very helpful for her. And so physical activity, this is at the time I initially intercept her, learn about her care, get to know her. Physical activity or any lymphatic mobilization like sauna, dry brushing, things that generally tend to be more gentle for folks would leave her bedridden for 1 or 2 days. I mean, she just did not have the energy to do life. So at intervention, she would be on oral antihistamines, inhaled steroids. On some days, her medication regimen would include a total daily dose of 4 milligrams of ketotifen, 180 milligrams of slow release Benadryl, chlorpheniramine malate, 16 milligrams, 1,800 milligrams of ibuprofen. And that was just to be able to get up out of bed and just to do her daily activities of life. So this was nothing strenuous for her. This is just to be able to get by. Now, her maintenance routine, even on a good day, would be 9 milligrams of low-dose naltrexone, so fairly high. We see it go that high, but it's on the high end for sure. So she's probably maxed out there. Nebulized albuterol and albuterol HFA inhaler, pulsed, so PEMF therapy, IV ozone, glutathione. She had a lot of antioxidants on board, UV blood irradiation, Myers cocktails most days out of the week. And as a pharmacist, one thing that we are trained to do is to do a med rec. So we ask the patients for their list of meds and supplements, and we do a medication reconciliation. And so that's what I asked her for. I said, I need your whole list of that. And she emailed it to me. A lot of these folks tend to be very regimented and scheduled and Excel spreadsheet people because they have so much stuff that they're on. They have to put it in there just to be able to remember what to take when every single day. So she sent it to me, and I'm used to looking at some pretty long lists, but hers really just took the cake. So her total regimen, first, what I was looking for was any duplications, anything that I could eliminate out, anything that I could optimize, anything that I could reduce. She had a total on her spreadsheet of 81 medications and supplements in total. For me to be able to go through this, I printed it out and I taped all the sheets together, and it was, I think, 3 or 4 sheets of medication. So that was the most I had ever seen. But what happened next was pretty incredible. So this was in January of 24, and that's when Amlexanox is initiated. So I remember talking to her Friday afternoon. Her doctor's office is closed. I said, listen, I went through your list. You're on 81 things. What was unbelievable to me is I could not find a single therapeutic duplication. So how do you feel about adding one more thing? And so she said, okay, I'm up for it. I said, well, the only reason I'm recommending that is because Amlexanox is something that we use to reduce polypharmacy. And I explained to her what that was and why I had confidence in this drug. On day 3 of taking Amlexanox, which is just that 40 milligrams once a day, she required only the albuterol inhaler, no longer needing the nebulized albuterol. 1 week after being on Amlexanox, she reported a marked reduction in airway mucus production, which was a really big deal for her. A lot of times, these folks, you'll see they're constantly swallowing because they've got so much mucus in there. So, especially for in-person evaluation, if you can see that that is happening frequently while you're having the conversation, that's probably excess production. And then after 2 months on Amlexanox, she notes improved breathing and significantly reduced symptoms of her MCAS, eliminating her need for inhaled and nebulized albuterol, along with most of her pre-existing regimen. So just 2 months in, 60 days into adding Amlexanox, she was able to slim down her routine of meds and supplements from 81 to just 17 agents. And so she is the one that I decided to publish here in actually the first edition of the Journal of Independent Medicine, which is an independent medical journal that is published by IMA. So that's Independent Medical Alliance, formerly FLCCC. And so this is a great journal that it's honest medicine. It is oftentimes a collection of case reports that people need to be seeing, especially of repurposed drugs or treatment approaches or wins that we need to be seeing as healthcare providers that we're not going to get the major drug trials done on, at least yet. So Dr. Yusuf Salibi and myself, we co-published this. We had, I think, 3 case studies in here. And so he had some wonderful information published in here as well. And he actually was the one, I credit to him coming to me and saying, hey, would you guys be willing to compound this thing called Amlexanox? And I thank God that he did that. So we really have been able to help a lot of people. And what is so incredible about this drug is that for the treatment refractory, for the chronically inflamed, for you know what I'm talking about when I say the hopeless and the desperate. Nothing else has helped, or they've tried everything and it has not moved the needle enough. The bedridden, this is a really big deal. In October of last year, went and presented at a conference at AAPS and talked about this, and I presented these case studies. And of course, we started getting a lot of prescriptions for it right afterwards because people had a lot of patients in their practice that they knew could be helped by this. And not 1 week later did it go on back order. And it was multiple patients every day calling up the pharmacy crying because they didn't know what they were going to do. They were rationing their Amlexanox. They were trying to buy it online. They were trying to call all pharmacies in the country to see who still had it. And we were all side blinded by this back order. So that was a sad deal. I'm really happy that we have it back. But I just say that to paint the picture of how much this has really moved the needle for people. For you to share more information about this with your patients if they're hesitant, or if you would like to read more about it as well, we do have several resources here. So, as always, every quarter I do publish a newsletter on our website, both for providers and for patients on the same topic, but they are in a little bit different language. So, that's available on the website. And then also, this is free. This article here, this is the first edition of Journal of Independent Medicine where that article is actually published. So I want to thank you so much for tuning in. I really love talking about Amlexanox. It's one that I take myself. It's one that I believe in. It's one that I've seen excellent results in for our patients. So I definitely wanted to share this with you and be sure it's something that you know that you have access to. Certainly, if you have questions, you can reach out to us at the pharmacy directly. We do receive prescriptions via fax, e-scribe, or verbal communication as well. And then, as I mentioned at the beginning, if we've not worked together before or had the opportunity to discuss your patients, I am one of the pharmacists, but my primary role at Physician's Preference is functioning as a physician liaison. So I'm there if you have questions about specific case studies like the ones I just presented. If you have tough to treat patients, call me up, we'll chat about it, and we'll get it figured out together as well. And also, I probably don't mention it enough, but as a prescriber, you actually get 20%, a 20% concession on your prescription. So if that's not already being applied or you don't get prescriptions filled with us yet, please just let us know on the front end. We'll add a note to your profile and be sure that that gets added and applied each time going forward. So I'm going to go ahead and stop sharing. And certainly if we have any questions, I'll be happy to take them. You can drop them in the chat or you can drop them in Q&A, whatever might be easiest for you. Let's see if we have anything here. I always do like to talk about pricing because I always get the question about pricing. So as far as pricing goes, the pricing is going to be a little bit different depending on the strength of the drug. And I may have actually closed out my pricing sheet, but you're gonna pay based off of a couple different factors, the dosing, and then of course the quantity, which is one of the things that I had mentioned is as quickly as we can get them up to their max titrated dose of whatever they're going to need. If they're purchasing less capsules, they're going to be paying less. So we always want to maximize that for the patient as well. So I don't think that I have any questions here. If you do, if anything comes up after the fact, or if you want to bounce off some specific ideas by me, please feel free to do that. You can reach me at the pharmacy, which again, I had that slide up there and it's in the chat, but I'll verbally give it to you here. And the number is 281-828-9088. And then also my email address is my first dot last name at physicianspreferencerx.com, which is really long. Okay, I do have a couple questions here. Is it recorded? Yes, it's recorded. Most of the time, these are recorded and will be distributed. Sometimes they are not for specific reasons, but this one will be. So in the next couple of days, if not early next week, you can expect to see a replay in your inbox. And then also a question, Th17 is a common pathway for many inflammatory conditions. Is there any relationship to diet? I'm wondering if you can further clarify that question for me as far as, I guess what you're asking is maybe our foods triggering that and triggering the T helper 17 cells, which is causing inflammatory conditions. And if that's your question, I would say absolutely. I am a big fan of genetic testing and nutrigenomics testing as well. So if you have further questions about that, you can let me know. But the relationship between genetics and foods also is a really big indicator for driving hard to treat symptoms and chronic inflammation. So there is an overlap between how the genes impact our how receptive we are to certain foods And yes, he's clarifying here inflammatory PUFAs, excess refined sugars, et cetera. Yeah, so I still would lean on nutrigenomics type testing because it tells us how the genetics impacts how we pull nutrients from both foods and vitamin mineral supplementation, or if we react negatively to them. Because even if we're putting healthy foods in our body, and let's take the mast cell overactivity person as an example, then what is going to happen? They are going to eat foods that increase their histamine, that cause inflammation, that cause toxicity. Maybe they're not clearing those nutrients out as fast as they could. They could be highly sensitive to high histamine foods, spinach, avocados, fermented foods, things like this. And what does it do? It really sets off their immune cascade. And so that's a lot of times where my head is at as far as diet impacting inflammation. That's an excellent question. And that's actually what this testing can test for as well. Can you please put the link to the article you wrote? Um, what I will do, actually, well, let's see if I can grab it. She's asking for the link to the article. Let's see if I can grab it. If not, what I'll do is I'll be sure that it goes out. And that's what I'll do. I'll be sure that it goes out in the replay because right now I'm in PDF format, so it's going to take me a while to pull that out. But yeah, I'll be sure that that gets included. And that way you can read through those case studies and you can have access to the IMA journal as well. They've come out with other editions since then too. Good questions. Any other questions that we have? If not, let me know if, whatever comes up for you. If you've got certain patients, like I said, I'm always available to you. That's why I'm here. So thanks again for showing up today, and we'll be back here in about 6 weeks to go over our next topic. You guys take care. Have a good one. Bye-bye.